So ma'am, 10 seconds will. So ma'am, it's 3, 2, 1. Over to you.
Okay. As we all know, India stands second place in the world for the diabetes prevalence and also ninth leading cause of the death. And diabetes is one of the major risk factors for the microvascular, including and macrovascular diseases. And also, today we light on the topic of diabetes management and including oral anti-diabetic drugs, DPP4 inhibitor, Vildagliptin. So for that, we have with us Dr. Pooja Garg and DNB, PG Diploma in Clinical Epidemiology and Endocrinology and Diabetes. And she is a consultant internal medicine in the Metro Hospital's Cancer Center in New Delhi. She has overall 13 years of experience, and her specialty interests include diabetes and internal medicine, critical care and emergencies, and seasonal illness. Ma'am, over to you.
Thank you for the kind introduction, Doctor. I think we can start the topic for today. Can I share my screen, please?
Yes,
can you? Yeah. All right. So I'll be sharing my screen. Yeah, are my slides visible?
No, ma'am.
So are my slides visible?
No, ma'am. No, ma'am.
No.
Ma'am, can you please reshare your screen?
Yes. One second. Give me a minute. Are my slides visible now? Are my slides?
Yes, ma'am.
Yes, ma'am.
Yeah.
Yes, ma'am. Ma'am, can you do the slideshow more?
Yeah, I am doing that.
Hello, ma'am. Is there any issue?
I think.
Ma'am, click on enable editing, please.
Oh, click on
enable editing button.
Where is the option? Yeah.
Upper side पे है मैम, येलो लाइन में है, enable editing, white box है. Protected view, be careful, files from the internet. मैम upper side पे है, enable editing मैम.
I'm unable to go on that. I don't know why is my cursor not working. I don't know.
Okay.
Oh my. Is it fine now?
Yes. मैम अनेबल एडिटिंग पे क्लिक करके
अभी भी नहीं आ रहा है?
नहीं मैम, वो अनेबल एडिटिंग पे पहला क्लिक करना पड़ेगा मैम।
Okay, all right, understood.
यस, अब ट्राई कीजिए। Ma'am, your screen is not visible. Can you please reshare your screen? Hello?
Yeah, I'm doing that. I'm doing that here.
Okay. Okay.
Is it visible?
No, ma'am, it's not visible. Yes, ma'am, it's visible.
Give me 1 more minute. I'm trying to open it again.
Okay.
Hope it's visible now.
Yes, ma'am, it's visible.
Yes, ma'am. Can you start, ma'am?
All right. So we shall be talking today on Vildagliptin and dapagliflozin, the combination that is available. I'll be talking on Vildamat DP. This combination that is available now in the market is a boon to the industry, for all our patients, especially. India, as we all know, is a hub of diabetes. Across the world, there are millions of diabetic population, but India stands 1 in 7 of all the diabetics worldwide. So it's heavily populated with the diabetic population. It's the second highest country with the prevalence of diabetes. Almost 74.2 million diabetics exist in India in 2021. So that's a huge number. So long-term glycemic control, why is it important? It's actually essential to improve the outcomes in diabetics. Every 1% decrement in HbA1c translates to reduction of risk of lower extremity amputation or fatal peripheral vascular disease by almost 43%. The risk of microvascular diseases reduces by 30%, 37% with every 1% decrement in HbA1c. If the HbA1c is reduced by 1%, there occurs reduction in risk of cataract extraction by almost 19%. The risk of heart failure reduces by 16% if there's a 1% decrease in HbA1c. The myocardial infarction reduces by almost 14% with a decrease of 1% HbA1c. Stroke risk reduces by almost 12% with a 1% decrease in HbA1c. So with every 1% decrease in HbA1c, now we know there's a huge decrement in all sort of risk factors that are associated with diabetes. Diabetes, as we know, is a hyperglycemic state. It's ultimately resulting from the ominous octet, we call it. The pathophysiologies are multiple, all contributing to hyperglycemia together. There occurs impaired insulin secretion at the level of islet cells of beta. There occurs decrease in incretin effect, increased lipolysis. There occurs increased glucose reabsorption at the level of proximal convoluted tubules. At the level of muscles, there occurs decreased glucose uptake. At the level of neurotransmitter dysfunction, there occurs hyperglycemia. thereby playing with appetite and satiety centers. There occurs increased hepatic glucose production at the level of liver. There occurs increased glucagon secretion at the level of islet cells of alpha. So they all together contribute to the state of hypoglycemia, thereby causing diabetes. Now, talking about the mechanism of action, what DPP4 inhibitors actually do. So we all know DPP4 inhibitors, how does the action of DPP4 inhibitor actually happens? With the intake of food, as we ingest the food at the level of intestines, there occurs secretion of active GLP-1, so which acts at pancreas and leads to activation of beta cells, leading to glucose-dependent insulin secretion, and it inhibits alpha cells, leading to glucagon suppression. So this active GLP-1 is inhibited or deactivated or broken down by DPP4 enzyme, leading to inactive GLP-1. So these DPP4 inhibitors, they inhibit this enzyme DPP4, thereby leads to prolonged activation of GLP-1 and leading to activation of beta cells, leading to glucose-dependent insulin secretion, thereby increases utilization of glucose by the muscles and the fat cells, and it inhibits alpha cells, leading to glucagon suppression, and thereby decreases hepatic glucose release and improves overall glucose control. So this is how DPP4 inhibitors act. Now this, we are talking of combination of DAPA and DPP4. So I'll tell you how they act together and thereby leading to inhibition of increment in glucose. So looking at SGLT2, so this is a diagram of a kidney or nephron where there are afferent and efferent arterioles. This is the proximal convoluted tubule, the segment 1, where most of the SGLT2 inhibitor, the SGLT2 receptors are, and SGLT1 receptors mostly predominantly in proximal convoluted tubule in the segment 2 and 3 are the SGLT1 receptors. These two lead to increased, they lead to glucose reabsorption. They are responsible for glucose reabsorption. Most of it is reabsorbed by the SGLT2 cells, almost 90%. 10% is reabsorbed by SGLT1. So what does this SGLT1 inhibitor do? SGLT2 inhibitors do? They inhibit this SGLT2 receptor here in proximal convoluted tubule in the proximal segment. And this SGLT2, as we can see, this receptor is a sodium glucose receptor whereby both enter the cells. This is at the basolateral site. This glucose then enters the interstitial fluid. So most of the glucose, 90% of it, is absorbed from the glomerular filtrate into these epithelial cells of proximal convoluted tubules via these SGLT2 receptors. Almost remaining 10% is absorbed here by SGLT1 in the proximal segment 2 and 3. Glucose then passes through the through this basolateral interstitial fluid capillary membrane to the interstitial fluid via GLUT1 and GLUT2. Now, what does SGLT2 inhibition does? Obviously, when there will be inhibition of this reabsorption of glucose, there will be occurring a glycosuria. So what will this glycosuria lead to? So this glycosuria will lead to decrement in weight, the increase in lipolysis, the increase in glucose neogenesis. There occurs decreased steatosis at the level of liver, thereby causing advantages in patients who are already a non-alcoholic fatty liver disease or NASH. There occurs osmotic diuresis, so there occurs decrease in blood pressure. There occurs decrease in angiotensinogen, decrease in endothelin, decrease in TGF-beta, and decrease in sodium hydrogen exchange pumps, decrease in fibrosis, and therefore decrease in CKD progression. And it also acts at the level of tubuloglobullar feedback mechanism, activates that, and therefore causes hyperfiltration. It leads to decreased hyperfiltration, decreases that intraglomerular pressure, and therefore causes reduced albuminuria. So therefore, leading to advantages in our diabetic patients, it reduces the CKD progression by reducing albuminuria and reducing the fibrosis. It causes total body reduction of sodium in water, as it causes glycosuria and thereby causes osmotic diuresis. So there occurs decrease in total body sodium and water, and therefore the chances of heart failure are bare minimal, or reduces the risk of heart failure, reduces the hospitalization due to heart failure. And this is how this entire mechanism plays a role. So all these together at the level of liver, there occurs increased ketone body production, that also increased ketosis, that also reduces heart failure. So they are all together. This SGLT2 inhibition basically provides advantages at the level of liver, heart, kidney, so everything, thereby proving it to be the best agent in patients who are at risk of heart failure, at risk of kidney disease, at risk of non-alcoholic fatty liver disease, who are obese. So all these actions leads to advantages in our diabetic patients. So now looking at what's happening in body, there occurs increased ketone production. There is decreased myocardial sodium hydrogen exchanger. There occurs almost no change in heart rate. There's an increased glycemic control. There's an increased endothelial function with this SGLT2 inhibitors. There occurs decreased vascular stiffness and thereby causing decreased systemic blood pressure. There occurs decreased plasma volume and thereby increases hematocrit and red cell mass. There occurs decreased plasma uric acid levels. As I said, osmotic diuresis and natriuresis occurs. Increases glomerular afferent arteriolar vasoconstriction by tubulo-glomerular feedback mechanism, reduces the intraglomerular hyperfiltration. It increases or enhances glycosuria and reduces albuminuria. It also reduces liver steatosis, thereby proving to be advantageous in patients with non-alcoholic fatty liver disease. It reduces skin sodium content, reduces the body mass and adipose tissue deposition and inflammation. It reduces leptin production, reduces advanced glycated products and products mediated effects and signaling. So all these mechanisms clearly demonstrate how SGLT2 inhibitors lead to pleiotropic effects in the body. Now looking at what the guidelines say, the ADA 2022 guidelines clearly highlight the importance of SGLT2 inhibitors in pharmacological management of hypoglycemia in adults with type 2 diabetes mellitus. The guidelines clearly recommend the first-line therapy depends ideally on the comorbid conditions of the patients. It's basically a patient-centric treatment factors. So the patient's affordability and considerations like management needs of the patient. So all these include mainly lifestyle changes, metformin, and if the indicators are, if patient is a high-risk case of ASCVD or is indicative of high risk of a heart failure or CKD, then the recommendation says individualize the HbA1c target or metformin use, and you can decide on the usage of GLP-1 receptor agonist with proven cardiovascular benefit or SGLT2 inhibitors with proven cardiovascular benefit in such patients. If still HbA1c is above the target, consider adding the different agent. Like if patient is already on SGLT2, we can consider adding GLP-1. If patient is already on GLP-1, you can consider adding SGLT2 inhibitor, or a thiazolidine can be considered if patient cannot afford both. So in high-risk category of patients who have underlying atherosclerotic cardiovascular disease or at high risk for heart failure or CKD, then consider these. If the patient has underlying heart failure, then SGLT2 inhibitors with proven benefit in heart failure are to be utilized. If patient has underlying CKD with albuminuria, preferably SGLT2 inhibitors, primary evidence of reducing CKD progression are supposed to be used. If patient has none of these high-risk factors, then depending on whether we want to reduce weight gain or we want to target hypoglycemia, then or the cost is a factor, accordingly we can decide what agent to be used in our patient. So treatment target has to be individualized, and depending on the risk factor that patient has, we can target the therapy for our patients. So now they incorporate agents that prove adequate efficacy, especially to achieve and maintain the glycemic control. If the higher glycemic efficacy agents like GLP-1 receptor agonists, insulin, or combined approaches can be used. If we have to minimize hypoglycemia, we can consider DPP4, GLP-1 receptor agonist, SGLT2 or thiazolidine. All these agents have a reduced risk of hypoglycemia. If still HbA1c is above the target, we can decide on other agents. To minimize the weight gain or to promote weight loss, the best agents are GLP-1 receptor agonists or SGLT2 inhibitors. If the cost is a factor, we can consider cheaper agents like sulfonylureas, insulin, and thiazolidine. So such agents can be decided based on what patient's pocket says. So linear plot, so talking about the Vildamac-DAPA combination, Vildamac-DP, so talking about the combination or Vildagliptin 100 once daily preparation and reference product, that is innovator Vildagliptin. Talking of efficacy comparison of both the Vildagliptins, that is 100 milligram once daily, the Vildamac, and innovator brand Vildagliptin 50 mg twice daily. So this is Vildamac 100 in pink. We can see here the concentration. The test product was bioequivalent to reference formulation, that is in blue. This is an innovator brand given twice daily. So mean comparative plasma concentration were almost similar and bioequivalent based on these pharmacokinetic parameters. So efficacy wise, our molecule Vildamac OD100 is at par with the reference molecule or innovator brand of Vildagliptin 50 mg twice daily. If we talk of linear plot of mean DPP4 inhibition versus the actual reference range product, we can see the mean DPP4 inhibition is almost similar, the similar mean percentage of DPP4 inhibition with Vildamac OD100 versus the innovator brand Vildagliptin 50 mg twice daily. So if we are talking of efficacy, we are seeing in all these graphs, efficacy wise Vildamac 100 OD is at par with reference product. So weighted average DPP4 inhibition over 24 hours after Vildamac OD 100 versus innovator Vildagliptin, almost weighted average of DPP4 inhibition over 0 to 24 hours is similar in the two groups. So in that efficacy wise, now we are too sure. Efficacy wise, this Vildamac OD100 is at par with reference molecule of Vildagliptin, innovator brand Vildagliptin 50 BD. So this is a once daily dosage. So this is an advantage for our patient. Once daily is easy to take. The compliance is improved. Not recommended, especially if creatinine clearance is less than 50. With or without meal, it can be taken. So that's not an issue. Only in patients where creatinine clearance is less, we need to modify the dose. So Vildagliptin reduces glycemic variability. So how is Vildagliptin as a molecule advantageous? It reduces mean excursion of glycemic excursions. Mean amplitude of glycemic excursions are reduced from baseline with the usage of Vildagliptin. The standard deviation of 24-hour glucose is also reduced from baseline to 16 weeks later when the Vildagliptin was used. So efficacy wise, it reduces glycemic variability, glycemic excursions are reduced. Vildagliptin also lowers albuminuria in patients who are diabetic and hypertensive, independent of the glycemic control. The glycemic control, whatever it is, with the usage of Vildagliptin, this albuminuria is reduced. The control arm, where there's a reduction in 9% and 20% patients had reduced albuminuria when the Vildagliptin was used. So clearly, with the usage of Vildagliptin, the rate in change of urine albumin creatinine ratio was grossly and markedly is visible in this graph. So now we know how Vildagliptin as a molecule is important, how our molecule, that is Vildamac OD100, is at par efficacy wise to the innovator molecule. Now talking about the safety profile, the cardiovascular and heart failure safety meta-analysis in almost 40 studies where almost 9,599 patients were included versus the comparator where 7,847 patients were included, underwent phase 3 and 4 studies included more than 17,000 patients, with almost 9,600 patients receiving Vildagliptin. 50% of the patients had high cardiovascular risk. Almost 18% also had history of cardiovascular disease. More than 40% of these had renal impairment. And the primary outcome studied here was a composite of MACE, non-fatal MI, non-fatal stroke, and CV death. Secondary outcomes studied here were non-fatal MI, non-fatal stroke, CV death, and heart failure events. The mean average of the patients included in all these studies was 57. Mean HbA1c was 8.1%, and diabetes duration being somewhere around 4 or 5.5 years. So all these meta-analysis revealed that there was no increased risk of MACE, that is primary endpoint. The only concern feature for we as clinician is the safety profile for our patient. One is the efficacy. We know now the efficacy of Vildagliptin. One is we should be satisfied with the brand. We have seen with the reference or innovative brand, our molecule is at par. Third is safety. Safety, we are talking no increased risk of MACE, primary endpoint in all these meta-analysis. The analysis also demonstrate there's no increased risk of MACE with the usage of Vildagliptin. You can clearly see here. Vivid has also demonstrated Vilda has no major adverse effect on reduction of left ventricular ejection fraction, even in patients who had underlying heart failure. Almost 254 patients were randomized to Vildagliptin versus placebo. Age group included was 18 to 85 years of age. Type 2 diabetic patients were taken who had heart failure with reduced ejection fraction, NYHA 1 to 3, and duration of diabetes was around 1 year. Endpoint taken was between treatment change from baseline and ejection fraction. So takeaway message from here was Vildagliptin had no major effect on reduction of left ventricular ejection fraction, even in those patients who had heart failure. Here, when it was compared to placebo, we can clearly see there was not major increased risk. So now we know how Vildagliptin as a molecule is a safe molecule. Efficacy-wise, data-wise, we have seen how safe it is. Now we are talking about the second component of the drug, that is Vildamac DP. We are talking now of dapagliflozin. We all know as clinicians the safety of dapagliflozin is clearly demonstrated and highlighted in Declare TIMI trial. So Declare TIMI 58 has clearly shown compared to placebo, dapagliflozin reduces the risk of CV death and hospitalization due to heart failure. In terms of renal composite also, dapagliflozin reduces albuminuria and provides advantages in our CKD patients by reducing the risk of CKD in our patient. Now talking about what the rationale is behind combining this Vildagliptin and dapagliflozin for our patient. Now we know both are wonderful molecules alone. So now how together they can act synergistically, I'll tell you. So there are two reasons behind it. One is we are talking about efficacy wise. It targets multiple places in this ominous octet. So in this red, we know these are DPP4. The actions of DPP4 are at multiple places. They act at the level of increased gluconeogenesis, decreased insulin secretion, and increased glucagon secretion. So it inhibits all this and promotes insulin secretion, reduces glucagon, and reduces gluconeogenesis, while SGLT2 inhibitors reduces glucose reabsorption. So this is how they act at multiple levels in this ominous octet. And thereby, pathophysiology-wise, they can act synergistically at multiple pathophysiological levels in diabetes and thereby manage the patient better. Second reason behind combining this is this, they take up the disadvantages like the dapagliflozin. What it actually does is it increases insulin-independent glucose excretion. We know it causes glycosuria, but it increases glucagon, therefore it increases the hepatic glucose output. How this disadvantage can be taken care of by Vildagliptin? They act at alpha cells of pancreas, as I have already discussed, reduces glucagon and therefore reduces hepatic glucose output. So this mechanism can be, nullified with the usage of this combination. So DAPA increases hepatic glucose output, Vildagliptin reduces it. So together, this will tackle glucagon surge that occurs because of dapagliflozin. This is how this combination wonderfully acts. So we can see here SGLT2 inhibitors increases glycosuria, therefore reduces glucotoxicity, reduces weight, reduces BP, reduces hyperglycemia. At the level of pancreas, the increased beta cell sensitivity increases glucagon. But DPP4 increases insulin secretion but decreases glucagon. So both can be nullified. At the level of intestines, DPP4 increases incretin effect, increases GLP1, increases GIP1, and therefore leads to reduction in hyperglycemia and leads to weight neutrality. So does prescribing actually a drug twice daily impact compliance? Of course it does. The meta-analysis of 13 studies have clearly shown impact of reducing dosing frequency on adherence to oral therapies. Our literature has also shown, and meta-analysis have also shown, if we prescribe a once daily dosing to our patient, there's an increased adherence to therapies, and therefore improved compliance, and adherence may subsequently decrease healthcare cost as well as improves outcome in the patients. And the third reason behind is both are to be given once daily according to PK/PD profile, and therefore improves compliance, adherence, and treatment outcome. There is also a lesser, this is fourth reason, there is a lesser incidence of genitourinary tract infection. Therefore, this fixed dose combination of SGLT2 inhibitor and DPP4 inhibitor is a wonderful combination. All these studies have demonstrated these together, when given, reduces the risk of genitourinary tract infection. So this appropriate use of fixed dose combination based on these glycemic factors thereby manages type 2 diabetes mellitus, and initiate the patient always with a lifestyle modification. In all your treatment naive patient where metformin is contraindicated or intolerant and HbA1c is more than 8%, in all these treatment naive patient, you can straight away start the patient on fixed dose combination of SGLT2 inhibitor and DPP4. In those treatment naive patients who are already with metformin, we can start them on this combination if patient's HbA1c is already very high. Those patients who are uncontrolled on metformin and still have high HbA1c, we can add on this therapy. So in all sort of patients, in all these class of patients, we can safely administer this fixed dose combination of Vildagliptin DP to our patients once daily. So to summarize my today's talk, this fixed dose combination is suitable option for type 2 Indian diabetic patients, as it's a safer, rapid, sustained glycemic control. It improves both insulin resistance as well as functioning of beta cells, helps reduction in body weight as well as blood pressure. These are the extra glycemic benefits we get out of this fixed dose combination. It reduces pill burden, improves adherence and compliance, and therefore overall cost is improved, and it is cost effective, patients pocket friendly, adherence can be highly justified, and therefore proving the outcomes. Thank you so much for today's talk. I think now we all know the importance of this fixed dose combination for our patients.
Yes, ma'am. Wonderfully said, ma'am.
Any sort of questions or anything that we need to talk or discuss?
Ma'am, I got one question, ma'am.
Yeah.
How safe it is in renal patients, ma'am?
As I have just discussed, the dapagliflozin reduces albuminuria and reduces the risk of CKD in our patients. So with the creatinine clearance more than 50, we can safely use it in our patients. But in those patients who have creatinine clearance less than 50, the dose needs to be modified and needs to be carefully administered. But safely, clearly in those patients whose creatinine clearance is more than 50, we can administer it very safely.
What are the regular challenges we face with this combination, as in your clinical practice?
Only problem that we face is genitourinary tract infection, and I think if we clearly counsel our patient to keep the urine hygiene, we can clearly sail through this. So I tell them to wash the private parts properly, drink a lot of water, keep the area hygiene. So I explain them beforehand when I start this combination. So I think that problem can be taken care of.
That's it, ma'am. Finally we will give the vote of thanks. As our esteemed speaker, you said wonderfully, ma'am, and the points were also described very wonderfully.
Thank you.
Thank you, ma'am.
Thank you to the McLeod team for inviting me for today's session. Thank you so much. Thank you, Dr. Lokesh.
Thank you.
Bye-bye.
Hello, Rohini. Hello.
Yes, thank you. So from here now I'm ending the meeting.
Okay.